is an 83-year-old Caucasian female. And let me come back later to my questions. I started to take care of her in the summer of 2019, and she at that time, among other things, told me that she'd had worsening memory problems over the past several years. She had already seen a neurologist once and been diagnosed with mild dementia. She experiences it as trouble recalling words, and she says that it takes her a while, and she can eventually get to it, but it takes her a long time. She was becoming increasingly frustrated with it. She was also pretty freaked out because her mom had dementia and she took care of her mom. And so she really was anticipating that happening to her. In her recent appointments with me, she's had evidenced trouble remembering appointments, and she herself thinks that her memory is worsening. When she was seen by neurology, I think it was 2018, they had ordered neuropsych testing, and she did not keep that appointment. They put her on Aricept. That, I think, caused diarrhea. At any rate, she stopped it. She was trying Namenda when I first met her. Then she thought it caused spots on her face. And that was the summer of 2019. When I saw her most recently, she was really fretting about her memory and wanted to restart the Namenda. We haven't spoken yet about how that is going. She does have a past history of lymphoma that was treated in 2015 and 16. She's in remission. She follows locally, although I think at some point she got care out of state as well. She has, the reason she came to me originally was she has ongoing leg and low back pain due to spinal stenosis, and she is currently being treated at a local pain clinic. Sometimes the treatments are helpful, sometimes they're not. She has a history of POTS, which explains some of her medications, and has mild chronic kidney disease. When I saw her, she had the labs that you see there, which were all normal. I had a report from the neurologist in the chart that mentioned the MRI of 2018 and mentioned a prior one that they said was from 2017, but it was actually from 2007. And they described, the neurologist described seeing a slight increase in chronic white matter ischemia on the MRI. There is the family history of dementia. These are her medications. So she also has hypothyroidism, evidently, which I failed to list in the chart. And she has, since her chemotherapy treatment, she's had some chronic shortness of breath, which she doesn't really talk about very much anymore. She uses the Proair inhaler for that.
Can I ask a quick question?
Yeah, most definitely.
Why is she on the Mestinon, the pyridostigmine?
That is because of her POTS.
Oh, okay.
Yes.
All right.
And I always have to remind myself of that because she came, I don't use that medication. She came to me on it, so I just have to look it up.
Okay, thanks.
Yeah. She lives with her husband. He's in his 90s. Before COVID, they would often come together. He's a reticent fellow. He doesn't really talk too much. Now that we're in, the pandemic, she's done I think all of her visits with me since then by phone. And she's having so many visits with the pain specialist that she really is not wanted to keep a lot of appointments with me or for any other referrals. She's estranged from her adult children, which makes her looming memory loss more frightening for her. They have a limited income. I tried to get her some help with somebody coming into the home, but she declined. And she has been the bookkeeper in this marriage, paying the bills and so forth. And she, last time I talked to her, she was still managing that, but I'm actually now somewhat worried about that because the last time I spoke to her, she really had trouble remembering her most recent story of her injections in her back. And it seemed like a recent significant decline to me. I put her independence is very important to her. She's very, very worried about ending up like her mom. And I really haven't spoken independently to her husband. So anyway, Mitra, if you could go back to my questions. I have a very basic question. This is Echo. I like asking basic questions. I would like to know, what is neuropsych testing? I don't know what that means. And I've heard people talk about it. So that would be helpful to me to know what that is. At this point, is that beneficial to her, or is this kind of...
Sure, that's a great question. I can actually take that one. So with neuropsych testing, we kind of look more in depth in terms of someone's cognitive abilities. So sort of like an MMSE, but a lot more in depth, looking at various aspects of their memory. Are they having a retrieval problem, or is it a consolidation issue? As well as looking at other aspects of their thinking, like attention and language, visual spatial skills. And we look for certain patterns to kind of give us a sense of what the etiology might be. So there are certain patterns that we see that kind of look more like an Alzheimer's profile versus maybe something more vascular. And based on all that, we kind of say what we think is going on, as well as make some recommendations that might be helpful in day-to-day functioning, as well as potentially other tests that might be beneficial.
That's helpful. And is neuropsych testing, do you do that for things other than, I guess you do it for any cognitive impairment?
Yep, anyone who's having any kind of cognitive difficulty, we often see for neuropsych.
Okay, gotcha.
Age ranges.
Thank you.
Sure.
And then the other, obviously, if you all have members have anything that you think diagnostically I need to do, I would appreciate that feedback or treatment. But my main question with her is how, you know, here's this semi-isolated, I mean, she's married, but the husband is the only potential caregiver. And how do I prepare her and them for what's coming for her? It's just, to me, been quite painful already. And you know, she's still doing kind of okay. And I just got to know her.
Right. Well, if I could jump in there, this is a good case. Thank you for bringing it to our attention. Thank you for presenting a case. I think you're right to be concerned about her. She may be in the sort of the full stages of dementia now, but she's starting to show some signs of not remembering her medications, which could be critical, particularly if she takes too many or doesn't take her medication, or if she is the bookkeeper and her husband is her only other person to depend on, and he's 90 and not the bookkeeper. They run the risk of having financial errors, or maybe scamming by unscrupulous others if there's nobody else managing or watching her money. Do you know if there's a medical power of attorney or a financial power of attorney?
Oh, that's a good question. I don't remember, and I could look, but off the top of my head, I don't remember. That's a great question.
Okay. So she's 82, her husband's 90. You know, it doesn't take much rocket science to project ahead. In 10 years, he'll be 100. And, you know, the prevalence of dementia does go up with age, and approaching 50% by the time you're 90. So her husband could develop dementia as well. And then you have two demented people in the same marriage that need help. And who would that dependent source be? Do you know why they're estranged from their kids?
I don't recall. She told me a little bit about it, and I also don't recall how nearby the kids are, whether they're out of state or not. I don't remember the details of that.
Yeah, it'd be useful to know, you know, how estranged are they? You know, might they come around if they knew mom and dad were dwindling or failing? You know, would they show up for the funeral? Mm-hmm. And if so, now's the time to show up when some help needs to be in place. Just to stick with the finance for a minute, barring that, if there is no other family member, then the question is there someone that can help watch their finances? That might be somebody they plan to will their money to. And that's another question. Do they have a last will and testament? It might be that person, whoever that is. It's not always necessarily even a direct family member. Do they have an accountant that helps them with their taxes, that could look over things? In Pittsburgh, where I train, they have what they call the Ursuline Center, which used to be a group of nuns. Now they're no more nuns. They're all lay people who get paid, but they will take people on like payees. And they will pay your bills for you, look out for your taxes, basically do the basic finance stuff that they can't do for themselves anymore. But I'd be very worried about, one question to ask is, if you got sick and your husband, let's say you both got the same bad flu, who would you depend on? Who would you call? And it could be a neighbor, it could be a church goer, it could be a friend, it could be somebody. And that brings me to the next point. You mentioned you were a little, he's a little reticent, and maybe you hadn't spoken with him alone. It often is good to speak with another family member who's not the demented one. Presumably both of them aren't dementing, to sort of find out what the worst case scenario is, which they may not talk about in the session with you, even if they're both in there. Sometimes they allude to it by rolling their eyes, or if they're behind the person, they might be, doing like, no, they don't, she's cooking and cleaning, and no, she isn't. And instead of causing a fight, to file it away and perhaps make an excuse to talk to the patient's husband by yourself. A couple of tricks that I use for that sometimes is to say, Mrs. Jones, I want to check your blood pressure again, because we want to be sure it's in a good range. So can you go with the nurse, and I'll just stay and chat with your husband and talk about it that way. If the patient's paranoid and doesn't want you talking to anybody, they're trying to put me away, or if you know that they're paranoid, then sometimes I tell the husband, you can call me anytime and we can talk about this over the phone too, wink, wink, or even hand them a card of yours that says, please call me when you have a chance to talk just one-on-one. And that's another way to sort of break the ice of getting the information that you need. In terms of your management, real quickly, and I want to spend most of our time on how do you relate non-pharmacologically. In terms of the workup, I didn't see a B12 or a folate or vitamin D. We often do those because they can help if they're low and you replace them. B12, particularly if it's really low, it can cause dementia, even permanent dementia, if it's low long enough. It's a vitamin that requires intrinsic factor, the protein secreted by the stomach, to bind the B12. So if you have stomach problems, achlorhydria, or you're on acid blocking drugs, or you have sprue or some sort of malabsorption syndrome, you can get low in B12. Autoimmune is the most common one, but it's very easy to fix and replace, and we watch it like a hawk. We sort of don't let it get below 400 before we do something about it. We don't wait till it's the bottom of the lab range. So be robust replacing that. Vitamin D, just about everybody in the cloud belt here is deficient in vitamin D. Some don't even test it, they just give it. But it's a good thing to do in case it's really low and she's inside all day or whatever. Folate, usually you're not deficient unless you're an alcoholic or starving, but it won't hurt to check that as well. One thing I didn't see in her history is her education. That can be a useful thing to know. Do you know if she is a high school graduate, for example?
I do not know.
Okay. Obviously you can tell some things by her vocabulary and her general education. Generally, people with more education are usually better at getting more resources. Either they know about them already, they may have had some psychology courses, or they're more inquisitive and sort of know how to do research, and otherwise they may need more help. Also, it'd be useful to know, did she work outside of the house, and in what sense? That can often give you a clue as to what her skill level is.
Mhm.
In this cohort of elders, of course, most of the time the women stayed at home and raised the kids and ran the house or the farm, and the husbands went out to work, but not always. And she may have worked during the war as a welder. That
Right.
would tell me she was pretty organized and pretty skilled. If she never left the farm and is afraid to, that tells me something too, that she's not terribly worldly or resourceful, and we may have to work harder to get her what she needs. So those were some of the notes that I wrote down. One thing, when she says, I'm afraid of getting dementia like my mother, this is a common theme that we hear. Of course, we can't prevent her from getting dementia if she's destined. We still don't understand why people get it. Some do and some don't, although it does look like there's at least a genetic component. But because her mother was demented doesn't mean she will be. It can skip her generation, and you can tell her that. That's not the extent of our understanding of the genetics, unless there's a loaded family history or we have more information to go by. But you can say, it may not hit you, but if it does, if you can't help it, that it's coming your way, how would you cope with it? So instead of avoiding the question, I usually take the confrontative approach to, what's the worst case scenario here? Okay, if you get dementia like your mother, does that mean your whole life was for naught? Does that mean everything you accomplished in life goes out the window? No. Having dementia is usually a long-term process. And if we understand that that's what's happening, then we can talk about how to prepare and prepare the way you want to prepare. And that's where we get into the patient-centered treatments. I've had some patients over the years that, don't tell anyone. I don't want so-and-so to know. And you honor that as long as you can, unless there's a dangerous situation, then you have to do what's right for protecting the patient. But I had one patient who lived alone. She may have been married one time, but was estranged from everybody, very independent, had a major mental illness as well as dementia. And she developed rectal bleeding, and it looked like it was probably a cancer.
Mhm.
And she didn't want anything done with it. And, we, in the end, we thought she was competent and we honored her wishes. And I didn't see her at the very end, but I assume she went on to pass away from that. But it's a slippery slope with dementia, because at some point they cross the line to where they're no longer of sound mind and body. And then we have to kick in with our judgment and the judgment of the family members and whomever we can gather together to make the best determination of what's right for the patient, and to honor their wishes as much as possible. Okay. So some people promise their loved ones, oh, don't worry, I promised I'd never put them in a nursing home. And we hear that a lot. And sometimes, when it gets to the really terrible end phase of dementia, where they're kicking and screaming and can't be controlled, and incontinent. By the way, incontinence and violence are the usual reasons to place somebody in a long-term care center. But let's say they get to that point and the poor spouse is saying, I know I promised never to do this, but I can't sleep at night, I can't, and you have to say, look, your wife wouldn't want this. You can have more quality of life with her if you have her go stay in the nursing home and you come refreshed every day with fresh flowers and perk her up and go home and get a night's sleep. The nurses and the staff will be there 24/7. If she needs to get up, if she's at risk for falls, if she needs to be fed or changed or whatever, you can't do all that. You're 80 yourself. So, you try to steer them to the most reasonable thing in your judgment, and you involve as many stakeholders that can grasp the situation. it's often kids, usually female kids, but it can be both, that are the ones, looking out for their moms.
Sorry, Dr. Miller. I actually wanted to ask Teresa as well if you had maybe some resources for Jen, maybe from the Alzheimer's Association perspective. Yeah.
Sure. Yeah, I do. In my presentation, I have some slides, and there's a reference list at the end. And I've sent the slide list so that you can go over it and maybe have a little learning session with anybody else in your office who wants to sort of discuss this topic.
Absolutely. I usually send the didactics out in the recap as well, so everyone will get the resources as well. Teresa, I think your volume might be a little low if you tried turning it up. It was really difficult to hear earlier, so I want to make sure we can hear you. It's still a little, I think it's muted now actually. If you maybe change your audio source, at the bottom left there should be by the mute button, if you click the little caret, you can select different audio sources.
While Teresa's trying to figure that out, anything from Dr. Howard or Dr. Keith or Melanie?
I guess, Jennifer, one of the things that I kind of think about is when I'm getting the history of the symptoms, in addition to getting the cognitive symptoms, I always pay attention and look for behavioral symptoms, even if they're mild: depression, anxiety, irritability, because the same structures in the brain that control those cognitive symptoms have a lot to do with these emotional symptoms. And as Mark was mentioning, the exacerbation of those emotional symptoms creates the greatest degree of burden for caregivers and can result in placement. And so having an early sense if those are developing or when they develop, it doesn't have to be really blatant like visual hallucinations, which is pretty obvious when it's happening and distressing. But kind of keeping an eye on those and managing them can be helpful early in the course so that you can keep things kind of settled down. Mm-hmm. And then, the question you ask early on is important, is kind of how you approach this with them. And that's like you approach for any other problem that a patient has, which is, how do we manage this the best that we can so you have the best quality of life? We don't have a key that we can stick in this and turn it off. That doesn't mean that you can't have a good quality of life going forward. And let's have a frank conversation about your symptoms and how things are going so we can manage them the best we can so you have the best outcome possible. And that approach is just amazingly reassuring to the patients, because this is scary stuff, because they've seen it in a relative. And if you have that calm kind of, we're just going to take this as it goes, they'll adopt that oftentimes too.
Great.
Okay, can you hear me now?
Yeah, loud and clear.
Good. I was working from another room, and so anyhow, we have lots of resources from the Alzheimer's Association for this exact scenario. You can either email me or I'll email you. Maybe we can talk a little bit off record, but you said that she's having trouble understanding, the diagnosis. She might be at the level or stage of the disease where she can't process it. So she might not ever really understand, kind of the dynamics of it and what to think. But, we have some really good training material. We have some really good just paper resources or electronic resources that I can send you and your office. I would be more than glad to kind of see exactly what you might be looking for. And then in terms of your office, if your office would like to have some training by us, I would be more than glad to set that up as well. We have about 12 preset education programs, ranging from, for caregivers to legal and financial discussions. And we actually have a really good one that's even called Difficult Conversations. Mm-hmm. And it talks about, obtaining your diagnosis, what you do with it, kind of planning, a little bit of planning, those types of discussions. So I'd be more than glad to go over that with you later.
Okay, thanks. I encouraged her to call you all at one point, and I don't know that she ever did that. But anyway.
Excellent.
I kind of feel like maybe, are you around Martinsburg?
No, Fayetteville. So.
Oh, okay. Okay.
Yeah.
Wrong way, sorry.
Yeah, that's okay. Yeah, that's good to know though, and probably getting some paper resources that I could hand to people when they're in the office.
Yes, absolutely. Absolutely.
Yeah.
And Dr. Ward, was there something you wanted to add as well? I noticed you unmuted.
Yeah, I was just gonna, no pun intended, echo what Mark said, which was, you know, I just really try to like reinforce to these patients that this diagnosis, while it feels very heavy in the moment, doesn't change who they are necessarily. And so like, you know, I feel like people think that they walk in one person and then they leave a completely different person once we've given them that news. So I try to reinforce to them that that's not the case. And then especially, you know, in this case, when she maybe doesn't have a lot of close people to advocate for her or express her wishes, if things get worse, I try to get a good sense of like, you know, what are your, not necessarily goals of care, but like if you ended up on a ventilator tomorrow, what kind of things would you want, just so that when and if it comes to that, you know.
Good. Helpful. Thank you.
I would just say too that early on, and if I assume that she's not terribly educated about this, because you know, just in the simplest terms, and this will work with very basic patients, is to say a couple of things. One is, well, it may be that the memory part of your brain isn't working as well as it used to. Okay, steer away from the dementia word, which is kind of a hot button for a lot of people, or the Alzheimer's word, because right now we're not sure if this is Alzheimer's or something else. So we're not really pulling the wool over her. But it's clear the memory part of her brain isn't working as well as it used to, and perhaps some other areas too. That's why we do this fancy testing we were talking about earlier that helps us get a bigger picture. Also, patients often feel guilty. You know, what am I doing wrong? Or why can't I remember? And so some guilt relieving statements are very useful to give. So, you know, this is not your fault. It's not normal to have memory as severe as what you have at your age. Some memory does slip with age, but not this far. You have a memory disease, a memory disorder. It's changes in your brain that are probably related to your genetics, and you may have inherited it from your mother. When we learn more about it, maybe we'll know for sure. There's a lot we still don't know. But if that's the case, this is not your fault. This is not a character flaw. You didn't ask for this, and you didn't bring it on. And I had one patient who thought she was losing her faith in God because she kept praying for her memory to get better, and it wasn't getting better. So she thought, I must be a bad Christian. And I'm like, no. You have a disease in the brain. That's why you can't remember, and it's not your fault. So helping them grasp things on a simple level like that can dispel some of the myths that they're carrying around with them in their mind.
Yeah, very helpful.
Teresa, you look like you were going to say something.
I'm a speech pathologist, so I always have something to say. But you were talking about, or I think in your summary, you said that, you know, she's having trouble with her medications. You know, there are some really good reminder systems out right now, and I can kind of send you a little bit of information on that as well. But I am a believer of a visual reminder, you know, so you can do like, you know, little, like maybe clocks. I mean, there are systems that won't even unlock until it's time, you know, for someone to take their medication. So, you know, there are lots of compensatory strategies that we can talk about and that we can do, you know, to kind of help someone in this stage where they're still independent, but they need some cues. And, you know, it just gives them a little more independence if you just set up some strategies for them to succeed.
Yeah, nice. Yeah, good. This is all extremely helpful. Thank you all so much for all the input.
I just wanted to say one other thing. You may have heard of cognitive remediation. For people who have had strokes, for example, or selective damage to certain parts of the brain, even within the range of symptoms we call Alzheimer's disease, you can have quite a variety of presentations clinically. And some of them can be improved with practice, with working on them. For example, recalling things, recalling names, memory retrieval. It helps to exercise your brain with words and reading, and social interaction is another way. Doing puzzles if they're so inclined, playing board games, doing strategy things together. Just planning something makes you use your brain. So those things won't make the dementia stop, but it may slow it down and may make them feel like they can do something. They don't have to just wait passively for this terrible disease to come at them like a train coming at them. So so that can be something you can engage them to do. You have to, keep it tempered. I have a bit of a funny story where the daughter brought her mother for evaluation. She was afraid she was going to say, "My mother has Alzheimer's disease," and she had practiced with her mother all the way in the car. They're going to ask you the date, so what's the date? And sadly, the daughter had been having her mother read Dick and Jane readers from first grade, hoping that she could remediate her and stop the memory process. So she was really trying hard. And one other quick story, another poignant one, was a couple lived together and they ran a business out of their home. It was a horticulture business. And the wife was the one with developing the dementia. She was the accountant and she was making all kinds of mistakes. Her husband was the brawn guy who put the stuff in the car. So when she was making mistakes, he would yell at her and she was getting upset. And he brought her in and said, "Doc, I want you to test her memory and tell me, if she has a memory problem. Because I've tried being nice to her, I've tried being mean to her, and nothing works. So I don't know what else to do." And after we did the evaluation, I said, "Look, your wife has a memory disorder. She can't recall enough of the things she needs to do her job anymore. You need to get somebody else to run those books because it's beyond what she can do." And he said, "You mean I have to look out for and help her out, Doc?" I said, "Exactly right."
Yeah.
So he got up from one side of the room and went over and sat next to her and held her hand.
Well, I hate to cut off any conversation short, but we do only have about 20 minutes left. So I want to leave time for the didactic as well. But this has been such great conversation. So thank you all. Thank you so much, Jen, for the awesome case.
Yeah, thank you all very much.
Thank you. And Teresa and Jen, I'll connect you two afterwards as well, so you guys can connect with the resources and everything. So Dr. Miller, I'll turn things to you for the didactic, and we have about 21 minutes now.
Okay, I'm going to talk really fast like this, okay? So I have a number of slides. I'm going to send them to you, but we've covered a lot of this already. So this is sort of the plan for today. There's a couple key things I want to stress, like defining executive dysfunction. First of all, a caregiver, and this is my definition, anyone who takes action to assist or provide surveillance for an elder who appears to be having a declining ability. And here's another key one. The line can be crossed unknowingly from a fully functioning parent-adult relationship to a caregiving role when they start to notice, you know what? Gee, mom hasn't changed the oil in the car in a year, or the furnace filter, or she's not even thinking about it anymore. Right there, that child has become a caregiver, though they didn't know it. And they're starting to provide surveillance that they didn't do before. All caregivers, however, are not alike. Some are wonderful. Some have their own problems. Some aren't that bright. Some caregivers have baggage toward the demented person, old hurts. There's a famous novel by Jane Smiley where she has to take care of her father who sexually abused her, and there ain't nobody else, so she's the only one left to do it, and she struggles with those terrible memories. So you have to assess the caregiver's ability to give care. Now, most of the caregivers are on this list. It's pretty obvious. Caregivers' reaction can be wonderful.
Dr. Miller, I hate to cut you off, but I think we're still seeing the first slide in the presentation.
Oh, it's not advancing?
No, it's still on the first slide.
Okay. Says I'm screen sharing. Why doesn't it change?
So if you go to the bottom, at the very bottom right, there should be something that kind of looks like a book that's opened. If you click that, it should turn it into presentation mode.
You're talking about the bottom of my screen.
The bottom right. I can also share my screen if that works for you as well. Okay, sort of seeing the slides now, but yeah.
Oh wait, here.
That's perfect. Yeah.
Did that do it? No.
Back. So if you click that bottom right, it looks like a textbook that's sort of open. That should make it into like a presentation mode. And then you can just click your arrows at the bottom to advance the slides. I can my screen as well and do that for you if you'd like. Just let me know.
Yeah, why don't you, to save time, because I don't want to mess with this. That way I can just keep talking. So we were talking about caregivers having their own agenda and their own baggage oftentimes. So we do have to assess the ability of the caregiver to give care, and sometimes they won't be able to. Is that your slide up there now?
Yes, so if you let me know when to go to the next slide, I'll do so.
Yeah, keep changing it. I'll tell you when to stop. Okay, right there. Back one. So some caregivers are full of empathy and proactive, and they can't do enough. Others are perplexed, they're angry, they're saying, why do I have to do all this stuff? Why can't you do it yourself? I'm too busy for this. I work too much. I don't have time for this. My kids are on drugs. They're driving me crazy. I can't be coming over here. All those things. And that tells you, they're not going to be terribly effective. Some get very sad. I'm sad I'm losing my mom right before my eyes. She used to be sharp as a tack, and now she's not. Some aren't very good copers. They tend to yell at their kids when they want them to do something, and they yell at their parents, and the parents don't take it very well. And the last one, of course, is the saddest one, where it can turn into either neglect, I'm not going over there anymore, or verbal or physical or mental abuse, even sexual and financial, makes the vulnerable elders vulnerable to any of those. Next slide. So here's the spectrum of cognitive impairment. You don't go from normal to demented overnight. There's a period of gradual changes. And during that time, oftentimes what we call executive function goes down, even before memory loss. As a matter of fact, you can diagnose dementia without memory loss if you have declines in executive function that interferes with someone's functioning. So families often misinterpret this executive function. I'll tell you more about what that is in a minute, but they misinterpret it as oppositional behavior, as laziness. Mom, why don't you clean up around here? It's a mess, meanness, or the spouse will say, he's falling out of love with me. He never asks me about my day anymore. He doesn't seem to care. And that's not from not caring, it's from the dementia process. And when you explain that, then they don't feel so hurt. Next slide. So here's ED, but we have to be sure we're talking about the right ED. This is the wrong ED. Next slide. So ED is defined by all these things. Some of these are neuropsychological terms, but if you go to the next slide, this is what changes. You see declines in insight. They don't get the big picture anymore. They can't see the forest for the trees. They have declines in judgment. I had one lady who was using the yellow line on the road as something you straddle with your car when you're driving, so you don't go off the road like you were playing one of those, electric car games. Impulse control is a problem. Your impulse control comes from your frontal lobes, which inhibits what your id tells you want to do. And without your frontal lobes intact, you can have impulse control problems. Problem-solving skills. I don't know how to turn on the TV with the remote anymore. I don't know how to use the washer. Social graces, telling dirty jokes at the wrong time. Empathy is requiring, it's an abstract concept that requires you to be able to put yourself in someone else's shoes and look at the world through their eyes and their senses. And that's a frontal lobe issue that goes down when you have dementia. Say nothing of initiative or being able to organize and plan things, multitask, all that's frontal lobe high level functioning that monkeys can't do, and either can people with dementia. Next slide. Here's an analogy I use to explain this to patients, the CEO analogy, who like watches over everything in the company to make sure it works right. And we all have a little CEO within us that organizes our day. Should we do this first, this second? How can we multitask, get the kids to school, pick up the laundry, drop the car off to get the oil changed, all that in the same day? That's our internal CEO. And with dementia, the CEO often goes on vacation permanently. And you just sort of do what's in front of you without thinking about all these other things you normally juggled easily. Next slide. So caregiver issues. The caregiver is not the patient, but they are part of the caregiver-patient unit. Caregivers sometimes need referred for their own help. They might be depression, they might need psychotherapy, they might need legal help, they might need help for their substance abuse, etc. And don't forget, the caregiver is going through a role transition too. You know, they don't want this job. They don't want to see their mother or dad go downhill, but it's happening and it's not waiting. So something has to you know, jump to attention. Next slide. So we work with the caregivers insofar as it impacts their ability to give care optimally. They're not our patients, and one reason that's important is in rare circumstances, you might even have to take action against the caregiver if you find out they're abusing their elder. So your patient is the elder with dementia, not the caregiver. Most of the time you're going to work with them and try to help them out, but they're not your patient, and don't forget that. Next slide. So what's person-centered dementia care? Basically, you know, how can we do our best for the patient to give them the highest quality of life? Which means we have to take into account what they value in life that's important. We design it around them, not the caregivers. Now, the caregivers may want to designed around them because they have to juggle their schedule to get them there, and they're often that sandwich generation, take care of their own kids and their parents, maybe grandparents too. They're stretched, they're stressed, and we have to acknowledge that. But in a perfect world, what the patient needs comes first. Next slide. So role transition with somebody with cognitive impairment would be all these things. You know, a lot of things are declining. And so we have to work harder to try to put back those things they can still do, or maybe a watered down version of it. So if they played bridge, but they can't do that anymore, it's too complicated. Maybe they can still play hearts. Maybe they can still do a flower pot garden instead of a big garden, something like that. So, and lastly, you know, accepting dependent role is sometimes necessary when your memory is failing. And I always say to them, look, if this happened to your husband, wouldn't you be helping him out? Well, of course, he's my husband. Well, then it's time for your kids to help you out. You raised them, and now it's their turn to give back. Also, I medicalize it by saying, look, you have the memory part of your brain isn't working as well anymore. Okay, just like if your leg didn't work, you'd let them help you get into the car, wouldn't you? Well, if your memory doesn't work, then let them call you to remind you about your appointments. It just makes common sense. You know, they care about you, they want to help, let them help. And don't worry about it. Don't fret about it. It's not a character flaw. I'll come back to that. Next slide.
Dr. Miller, I have to interrupt you to tell you that my own mother calls it the diaper account. She tells us we're paying back the diaper account. She changed plenty of diapers. Now it's payback.
I always like that one where the parents say, I brought you into this world and I can take you out, if you don't behave yourself. Anyway, so patient-centered care, you need to get to know the patient. What floats their boat? What did they like? Did they like flowers, dancing, beautiful clothes, cooking, what made them feel good, and try to include them in that. I love the story of the salad making. So let's say it's the wife is getting demented, and the husband's taking over the cooking, and he'll say something like, "Oh, she makes a mess in the kitchen. She gets started on things and forgets what she's doing." And so I just tell her, "Hey, get out of the kitchen, go watch TV, and I'll make dinner." And I said, "You know what? That's not necessarily the best thing to do, because her forte is being in the kitchen, and you're just taking that away from her when you tell her to go sit and watch TV. So here's an idea for you. Instead of telling her to go make a salad, tell her to go get the salad bowl. And when she does that, tell her to go get the lettuce. And then when she does that, tell her to go get a carrot and peel it. And you can help her build a whole salad that way, but you have to wait till she does each step, because that's the problem. She can't keep all the steps straight, but you can do each one just fine. So try that, would you? And let her help you in the kitchen. Even if she doesn't do a great job, thank her for making the salad and tell her how delicious it was. And that'll help maintain her self-esteem, because depression is very common when people feel they don't have a place anymore. And that's what you can do a lot to help. Next slide. So this British guy coined the term. I'm going to go through these somewhat fast. You'll have the slides. Next slide. Starts with conversation. Again, get to know the people. Who are the stakeholders? What can each of them do? And many of them do this intuitively. They just go to it. Sometimes they need a little prompting, and then they'll do it. And others are so distracted they never can do it. So you take what you have and work with it. Next slide. Again, recognizing all their backgrounds and the things that made them. I have one couple, they're two different flavors of Christian, and the demented one insists the Sabbath is Saturday, it's not Sunday, and she can't get that through her head. How's she gonna ever get to heaven if she doesn't know the Sabbath is Saturday? And he'll argue all night and quote the Bible and everything, and finally, his wife has learned just shut up about it, even if she doesn't agree, and that may be the best path forward for that. So you do what you can. You try not to sweat the small stuff. Next slide. So advice for caregivers: accept the identified patient as they are, not as their former selves. They've often had some loss already. If you look at the MRI, and a third of their frontal lobes are missing because they've atrophied, they've lost some of those connections that made them who they are. And so you have to deal with them how they are now. There might be vestiges of their old self, and you may see more of it some days than others, and take advantage of that is the advice you give them, but they still need help even if they don't recognize you anymore, for example. So you want to modify your expectations. If they're way up there in the sky, you're going to be disappointed. You keep them basic and practical. Watch your tone when your communication, be respectful. I try to model that for patients. So even from the get-go, when they come in for the first time, and let's say the hard driving daughter wants to come and tell the story, and she starts, jumps right in like her motor's running 50 miles an hour. And you have to say, wait. I want to get to you in a minute. I want to hear everything you have to say. But first, Mrs. Jones, how are you today? How was the ride in? Did you have breakfast? It's a beautiful day, isn't it? I love that jersey you have on. And I engage the identified patient and model respect for them to the rest of the family, who may have not let them talk at all. They just talk over them and talk for them, and I won't let that happen. So I model from the first minute they come in. You do want to help the caregivers acknowledge that they feel like they're grieving. They're losing someone they love, who's not looking the same as they used to. Also to acknowledge the fact that, you know, I was sexually abused by her brother, and now she's never going to get it. And I was waiting for the right time to tell her, and now that's never going to come. And boy, I have to come to terms with that. I've heard that story before. Next slide. What concrete examples can you give to help caregivers give patient-centered choices? Well, simple things like, what would you like for dinner? Would you like hamburger or spaghetti? Would you like this or that? Dressing, what would you like to wear today? Let's go pick something out together. And even if it's odd looking colors, if they really like it and they're going to mostly stay in the house, what do you care? Let them wear pink and green if it's something they picked. Watching TV, different activities. Provide a range of psychological interventions you know they like. If they loved animals, take them to the zoo. You know, go see the petting zoo. Whatever it is that floats their boat, take time to go do it with them. And you'll see them lighten up and brighten up. Care for financial things we talked about already. Spiritual beliefs, you know, if it's important to them, take the time and get them to church. Oftentimes that's the only thing they have to hang on to when it feels like things are slipping. And if it's important to them, make sure you get them there. Next one. The benefits of doing this can reduce agitation and aggression. A lot of times when I work with patients on the inpatient unit, you don't know why they're agitated because they can't tell you anymore. You have to guess. Sometimes maybe we guess right because they get better. I had a patient once, I read about a patient once who clutched her little baby. It was like a doll, and she wouldn't let it go all day long, even though it was very dirty and nobody could get it off of her. It turned out she had lost a child when she was younger, and in Freudian terms, you know, this would have been a transitional object, you know, the embodiment of something you take care of. You couldn't really talk about losing the child, but symbolically she was holding on to that baby doll for dear life, and you bet it was connected. So medications can play a role. That's a different talk. We'll come back to that. Next slide. So different models, Alzheimer's mentioned, I'm going to show you some of their slides, but other people have come up with this program called CARES, AARP has one. I wrote a book about adapting IPT for cognitively impaired, and they're all in the slides if we run out of time, but we'll show some as many as we can. Next slide.
Dr. Miller, we have about 2 minutes left until 5 p.m., so we could also do this as a part 2 for another date as well, whichever you prefer.
Yeah, it sounds like there's a lot of interest, and maybe we should have this 2 minutes for questions, because we covered a lot of ground. And you have the slides too. You can read them; they're pretty straightforward. But any thoughts get brought up by anything we've said so far today?
Absolutely. Thank you so much. Any questions for Dr. Miller and the first part of this didactic on patient-centered care? Any comments you'd like to share? That was funny, Jennifer. Thank you for adding that earlier about what your mom would.
My mom will be thrilled. I'll probably she can go on YouTube and see that I quoted her. Yeah, that was all very helpful, and probably another one of my upcoming cases will be about a couple that I'm taking care of where they're both my patients, so it presents a really interesting challenge caring for the caregiver and the patient with dementia, but it all still applies. I mean, it's all, you know, honoring the person with dementia and honoring the caregiver too.
Right. And in most situations, if I could just add, you know, the PHI issue is not an issue for most people in their immediate family. They're like, yeah, sure. If she wants to help. If you want to talk to her, talk to her. You know, I have nothing to hide, you know, more the merrier. So if they both say that, then there's not a conflict either way, and you just do what you can for the unit, the couple, and both individually. So,
well, thank you a lot.
You're very welcome.
Thank you all so much. It is 5 p.m., so it has come to the end of the session hour. So thank you all so much. Thank you, Jen, for the awesome case again. And thank you, Dr. Miller. I'll work with you afterwards to do a part 2. We can schedule you to finish that second part. I do have a couple housekeeping announcements. Just a quick reminder, we're going to do a really quick poll at the end of today's session. So if you can hold on for a few minutes, that would be wonderful. We are also gathering some more information still on comfort level and caring for patients with memory health conditions and everything. So we'll be sending out a REDCap link to fill out that survey in the recap email. If you could take a moment to fill that out, that would be awesome as well. And last but not least, our next session will be on December 1st, and Dr. Hout is providing the didactic on signs and symptoms and assessment tools. So keep an eye out for that reminder email. Thank you all so much. I'm going to launch the poll now. Anytime you guys finish it, just feel free to
Thanks, Jennifer.
just log off. Thank you.